Pediatric Multisystem Inflammatory Syndrome, or Multisystem Inflammatory Syndrome in children, is a systemic disease involving persistent fever, inflammation and organ dysfunction following exposure to SARS-CoV-2, the virus responsible for COVID-19. This syndrome appears similar to Kawasaki disease. It can also show features of other serious pediatric inflammatory conditions, including toxic shock and macrophage activation syndromes. Failure of one or more organs can occur. Early recognition is essential, followed by prompt admission to hospital for specialist attention. Older children tend to be affected. The first symptoms may be acute abdominal pain, diarrhea or vomiting. Low blood pressure is common. Other symptoms can include conjunctivitis, rashes, mucous membrane changes, enlarged lymph nodes, swollen hands and feet, sore throat, cough, fainting, irritability and confusion. Respiratory symptoms are not always present. Myocarditis is a frequent form of cardiac involvement. Others may include pericarditis, valvulitis, and coronary artery abnormalities, such as dilatation. Cytokine storm may occur. Oxygen therapy may be needed, and some children require pediatric intensive care. Limited information exists regarding clinical course of this life-threatening disease, which has occasionally proved fatal. Several major health organizations have issued statements on this emerging condition. In particular, the World Health Organization has published a preliminary case definition for diagnosis and tools for standard reporting of cases. The Royal College of Pediatrics and Child Health has issued guidance on diagnosis and clinical management. The Centers for Disease Control and Prevention has provided recommendations for diagnosis and reporting. Although the condition is thought to follow SARS-CoV-2 viral infection, antigen or antibody tests are not always positive. Exclusion of other possible microbial causes is always essential for differential diagnosis. The biological mechanism of the disease is not known, and no risk factors are known either. The condition is considered rare. The European Centre for Disease Prevention and Control has rated risk to children in Europe as being low overall, based on a very low likelihood of a child developing this high-impact disease. So far, reports have largely regarded children in various parts of Europe and the US. It is unclear whether the condition has gone unrecognized elsewhere. Background: symptomatic cases of COVID-19 in children have been relatively uncommon, possibly because they generally experience milder disease. While cases with severe symptoms are exceptional, they can occasionally require intensive care. A few children with evidence of SARS-CoV-2 infection or exposure to COVID-19 display clinical features corresponding to the diagnostic criteria of Kawasaki disease, sometimes accompanied by shock. Kawasaki disease is a rare syndrome which mainly affects young children. It is a form of vasculitis, where blood vessels become inflamed throughout the body, and it results in a persistent fever. Recovery typically occurs spontaneously, though some children go on to develop mid-sized or giant coronary artery aneurysms in the heart, a potentially fatal complication. Symptoms of toxic shock occasionally occur, an association sometimes referred to as Kawasaki shock syndrome, which is characterized by systolic hypotension or signs of poor perfusion. While the exact cause of Kawasaki disease is unknown, one plausible explanation is that it may stem from an infection triggering an autoimmune and/or autoinflammatory response in children who are genetically predisposed. No specific diagnostic test exists for Kawasaki disease, and its recognition is based on various combinations of clinical and laboratory findings. Review of the characteristics of cases of Kawasaki-like disease with links to COVID-19 prompted a preliminary case definition of PIMS. Characteristics: PIMS is a systemic inflammation, involving persistent fever, inflammation and organ dysfunction, which is temporally associated with exposure to COVID-19. Onset may be delayed or contemporary with ongoing SARS-CoV-2 infection. It may occur several weeks after the initial infection. The condition may match some or all of the diagnostic criteria for Kawasaki disease, or for Kawasaki disease shock syndrome. It tends to affect older children and adolescents, whereas Kawasaki disease most often occurs before the age of 5. It can also share clinical features with other pediatric inflammatory conditions, including toxic shock syndrome, septic shock, and macrophage activation syndrome. Children may present with symptoms not commonly associated with Kawasaki disease, including unusual abdominal symptoms, accompanied by pronounced inflammatory markers. Acute gastrointestinal symptoms can include abdominal pain, and diarrhea or vomiting. Low blood pressure is common. Other symptoms may include conjunctivitis, rashes, mucous membrane changes, enlarged lymph nodes, swollen hands and feet, sore throat, cough and respiratory symptoms, fainting, irritability and confusion. Some children display features of a cytokine storm, including high serum interleukin-6 levels, and need inotropic support to maintain cardiac output. Cardiac involvement and features of macrophage activation syndrome appear to be more frequent than in Kawasaki disease. Characteristic laboratory findings that are not usually encountered in Kawasaki disease include leukopenia and very elevated levels of ventricular natriuretic peptide, a marker of heart failure. Cardiological findings may include clinical features of myocarditis, pericarditis, valvulitis, or coronary artery abnormalities, such as dilatation. Some children may have coronary artery aneurysms. Shock is often of myocardial origin. Respiratory symptoms are not always present. Breathing difficulties are often linked to shock. Limited information currently exists regarding clinical course, which tends to be more severe than with conventional Kawasaki disease. Early recognition of the disease is essential, followed by prompt admission to hospital, with referral to specialists. Supplemental oxygen may be required, and pediatric intensive care may also be needed. Myocarditis is frequent. Fatalities have resulted from complications of extracorporeal membrane oxygenation. Some children exposed to COVID-19 also appear to have a less severe Kawasaki-like disease. Diagnosis. Clinicians worldwide have been urged to consider this condition in children who display some or all the features of Kawasaki disease or toxic shock syndrome. Early recognition and specialist referral, including to critical care, is considered essential. The initial case definitions released by the World Health Organization, the Royal College of Pediatrics and Child Health and Centers for Disease Control and Prevention all include involvement of more than one organ system, along with fever and elevated inflammatory markers. In particular, the preliminary WHO case definition is for multisystem inflammatory disorder in children and adolescents. The WHO has established a platform for standardized, anonymized clinical data, along with a dedicated case report form, and underlines the urgent need for collection of standardized data describing clinical presentations, severity, outcomes, and epidemiology. Diagnostic guidance by the RCPCH proposes a case definition which has also been endorsed by an expert panel convened by the American College of Cardiology. Key clinical criteria set out in the RCPHC case definition are persistent fever, inflammation, and evidence of organ dysfunction, coupled with additional clinical features, including laboratory, imaging and ECG findings. Coronary artery abnormalities, such as dilatation, may be apparent at echocardiography and ECG. Biomarkers supporting the diagnosis include abnormal fibrinogen levels, high D-dimers, high troponin, low albumin, and high ferritin. According to the RCPCH definition, the child may test positive or negative for SARS-CoV-2, but other possible microbial causes need to be excluded. The CDC case definition for MEC comprises individuals aged less than 21 years presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization, with multisystem organ involvement. It also requires that there should either be a positive antigen/antibody SARS-CoV-2 test or COVID-19 exposure in the 4 weeks before onset of symptoms, along with exclusion of other plausible diagnoses. This case definition is quite broad. The CDC advises health providers in the United States to inform their public health authorities of suspected cases, even if they also meet full or partial criteria for Kawasaki disease, and to consider MEC after any childhood fatality in which there is evidence of SARS-CoV-2 infection. Differential diagnosis. It is essential to exclude other alternative microbial causes, including bacterial sepsis, staphylococcal and streptococcal shock, and infections associated with myocarditis, such as enterovirus. Differential diagnosis with Kawasaki disease can be challenging, given the lack of a diagnostic test for either condition. It is not currently known whether the newly described condition is superimposable with Kawasaki disease shock syndrome. Since prompt diagnosis and timely treatment of actual Kawasaki disease is important to prevent complications, a call has been made to keep a high suspicion for Kawasaki disease in all children with prolonged fever, but especially in those younger than 1 year of age. Treatment. The RCPHC has provided guidance on clinical management and treatment. Little specific information is available regarding therapeutic effectiveness. Anti-inflammatory treatments have been used, including intravenous immunoglobulin and corticosteroids. Cases requiring steroids due to resistance to intravenous immunoglobulin may be more common than in Kawasaki disease. RCPCH guidance recommends that all affected children should be treated as having suspected COVID-19, and that for mild or moderate disease supportive care alone may be sufficient. The RCPHC recommends that any administration of a candidate antiviral therapy should whenever possible be performed in the context of a registered clinical trial. In the UK, ongoing collaborations are aiming to ensure that all infected children are able to take part in a mechanistic study such as DIAMONDS or SARC-CCP. Treatment strategies are being considered to prevent serious long-term complications such as coronary artery aneurysms. Causes. Based on laboratory findings, it has been hypothesized that the condition may be related to COVID-19. Further characterization of the syndrome is essential to identify risk factors and help understand causality. Improved understanding will have potential implications for clinical management. It has been emphasized that the potential link of this rare condition with COVID-19 is neither established nor well understood. A temporal association between SARS-CoV-2 infection and clinical presentation of the syndrome is plausible. A causality assessment found that temporality was among the 5 Bradford Hill criteria that supported a causal relationship between SARS-CoV-2 infection and the development of the syndrome. It is unclear to what extent this emerging syndrome has a similar etiology to Kawasaki disease. Genome-wide association studies should provide insights on susceptibility and potential biological mechanisms. Mechanism. The pathogenesis is unknown. SARS-CoV-2 could have one of several roles. It could act as trigger for the condition either directly or indirectly. It has been suggested that, as with Kawasaki disease, one possible mechanism is antibody-dependent enhancement, whereby development of antibodies facilitates viral entry into host cells. It has also been suggested that the condition may be caused by the cytokine storms induced by COVID-19. The characteristic ability of coronaviruses to block type I and type III interferon responses could help explain a delayed cytokine storm in children whose immune systems struggle to control SARS-CoV-2 viral replication, or are overwhelmed by a high initial viral load. On pathophysiological grounds, the frequent gastrointestinal presentation, along with findings of mesenteric lymph node inflammation, suggests predominant replication in the gastrointestinal tract by a virus with a known predilection for enterocytes. Association of Kawasaki-like disease with COVID-19 could support the view that SARS-CoV-2 can cause systemic vasculitis by targeting endothelial tissue via angiotensin-converting enzyme 2, the protein which the virus uses to gain access to cells. Key research questions regarding the underlying molecular mechanisms that lead to MES following exposure to SARS-CoV-2 include identification of any genetic predisposition factors, any associations with particular viral variant/S, any molecular patterns capable of triggering the autoimmune/autoinflammatory responses. Another key question is whether the molecular mechanisms that trigger autoimmune/autoinflammatory responses in children with MES and adults with severe COVID-19 are similar or distinct. It has been noted that a leading hypothesis for the pathogenesis of Kawasaki disease also involves a hyperinflammatory response to viral infection in some genetically predisposed children, and that SARS-CoV-2 is now included in a list of implicated viral triggers. Epidemiology. Epidemiological information is scarce. Suspected cases began to be recorded in Europe and the US around April 2020, and several hundred possible cases were recorded by mid-May, along with at least 5 fatalities. A nationwide surveillance program in France, set up to investigate the temporal relationship between SARS-CoV-2 infection and PIMS, revealed that 95 of the 156 cases of Kawasaki-like disease notified between 1 March and May 17, 2020 were confirmed or probable post-COVID-19 cases. Clinicians in Bergamo reported an apparent 30-fold increase in the incidence of Kawasaki-like disease during the first 6 weeks after the arrival there of SARS-CoV-2 virus infection. This emerging diagnosis is considered rare. A rapid risk assessment conducted by the European Centre for Disease Prevention and Control concluded that the overall risk to children in the European Union, European Economic Area and the UK is considered low, based on a very low probability of in children and a high impact of such disease. Regarding geographical distribution, it is unclear whether the reports of cases in Europe and North America reflect a true pattern, or whether the condition has gone unrecognized elsewhere. No apparent increase in cases of Kawasaki disease was observed in Asian countries such as Japan and South Korea, where Kawasaki disease is usually much more prevalent than in Europe. Reports from France and the UK raise the possibility that children of Afro-Caribbean descent may be at greater risk, plausibly due to a genetic predisposition. It has been suggested that this condition may affect more children of African American, Caribbean, and Hispanic ancestry, whereas Kawasaki disease affects more of East Asian ancestry, although the role of socioeconomic and other environmental factors in such distinctions is unclear. This is a newly proposed clinical entity, and an opinion has also been expressed that cases meeting the criteria for Kawasaki disease or myocarditis should be diagnosed and treated as such. Concerns have also been raised regarding the potential for missed or delayed diagnosis of Kawasaki disease due to heightened diagnostic suspicion for the new entity. Hopes have been expressed that study of the new condition may help understand the hidden mechanisms behind Kawasaki disease. History. Cases of Kawasaki disease with concurrent SARS-CoV-2 infection have been recorded among children in Europe and in the United States since April 7, 2020, when a report was published by the American Academy of Pediatrics regarding a case of classic Kawasaki disease in a 6-month-old girl who tested positive for COVID-19. In this case, COVID-19 did not appear to have significant clinical implications. On 25 April, concerns were initially raised in the United Kingdom regarding a cluster of children of various ages presenting with a multisystem inflammatory state who required intensive care, and who all displayed overlapping features of toxic shock syndrome and atypical Kawasaki disease with blood parameters consistent with severe COVID-19 in children. Details of the 8 cases which helped trigger this alert were later reported in The Lancet, where the authors summarize the clinical picture as a hyperinflammatory syndrome with multi-organ involvement similar to Kawasaki disease shock syndrome. Accounts of analogous cases, including some that appeared less clinically severe, were also being informally shared among clinicians around Europe. The EU's early warning and response system flagged suspected cases in Austria, Germany and Portugal that had tested positive for SARS-CoV-2. In Bergamo, at the heart of the COVID-19 epidemic in Lombardy, a cluster of 20 cases of Kawasaki disease appeared to be roughly equivalent to the number commonly recorded there over the course of 3 years. In France, the government reported on 29 April that around 15 children were in hospital in Paris with symptoms of Kawasaki disease, an observation which prompted the organization of National Surveillance Program for recent cases of Kawasaki-like disease. On 1 May, the RCPCH published a preliminary case definition based on review of the characteristics of the cases identified in the UK, accompanied by some clinical guidance. 2 weeks later, on 15 May, 2 further preliminary case definitions were published separately by the WHO and by the CDC, while the ECDC released a rapid risk assessment of the condition on behalf of the European Union. On 4 May, The New York City Department of Health and Mental Hygiene issued an alert to identify children with the condition in New York City hospitals, where 15 such cases were already being treated. By 12th of May, some 230 suspected cases had been reported across the EU, EEA and UK. In the United States, more than 200 cases were suspected by mid-May, including some 145 in New York. As of May 11, 2020, 5 fatalities were reported. On 2nd of June, news emerged of a first case of MERS-C diagnosed in Peru. In Russia, 13 children had been treated by mid-June for a multisystem inflammatory syndrome at the Morzov Children's Hospital in Moscow, including a 2-year-old girl with a COVID-19 infection who died on 23 May following an initial diagnosis of suspected Kawasaki disease. In peer-reviewed medical journals, case series and related studies of the new condition were rapidly reported from countries including the UK, Italy, Spain, France and Switzerland, France, and the US.